So friends, just remember this pic. This is the pictorial depiction or Jaboulay. And we have given an angle stitch as the mid-pyloric and we are giving traction. So there is no need to mobilize the pylorus. There is extensive scarring. And so pylorus is undivided as highlighted. And we approximate the, just below the scarring, we approximate the greater curvature of the stomach to the duodenal part. So these stitches are as close to greater curvature and middle part of the duodenum because otherwise subsequent closure will be difficult. Welcome to our channel viewers. So this is going to be an interesting video series and in which we'll discuss about Heineke-Mikulicz, Finney, Jaboulay and Michelassi. Friends, most of you are already aware about first three, that is Heineke-Mikulicz, Finney, Jaboulay, and Michelassi is a new addition, and we will discuss briefly about this also. So this is part one that will be focused mainly on the theoretical discussion, and the second part will be a demonstration of live surgery in two cases. First will be corrosive, and the second will be chronic duodenal ulcer. And we also added feeding genostomy in the corrosive case. And friends, we have also discussed about Gamby stitch because Gamby stitch is the preferred stitch for closure of the pyloroplasty. So theoretical part and live demonstration will be in the second part of this video series. So the main objective of this video series will be to learn about different type of stricturoplasty or pyloroplasty, that is Heineke-Mikulicz, Finney, Jaboulay and Michelassi, to learn the theoretical and practical part of Gamby stage and live demonstration of surgery, which I said it will be in two cases of corrosive and chronic duodenal ulcer with gastric outlet obstruction and feeding genostomy addition in the corrosive case. So friends, the indication of pyloroplasty are limited in the present era, and there are lesser and lesser cases in these times. So mainly the indication which you may get during your surgical career will be pyloric stricture or duodenal stricture, which can be because of the acid reflux disorders or because of the acid ingestion, as in one of our case, or when the vagus innervation of stomach is interrupted during pancreas selective vagotomy, or by dealing with the esophagogastric junction tumors, there is section and the vagus nerve get interrupted. The advantage will be it does not alter the continuity of gastrointestinal tract, that is, the normal continuity of stomach to duodenum is maintained, and there are decreased possibility of margin ulceration. For example, we have seen in quite a number of cases that after gastrogenostomy, when the normal mucosa of jejunum is exposed to the high acid content, it leads to the margin ulceration of the jejunal mucosa. And there we have witnessed few cases of perforation also at the GJ site. So that possibility is less after the pyloroplasty, and it is a simple procedure, technically simple, with less morbidity and mortality if we choose and apply the technique properly. The pyloroplasty most commonly used are Heineke-Mikulicz pyloroplasty and Finney pyloroplasty. And remember that if there is a marked inflammatory reaction or there is severe scarring, deformity on the duodenal wall, then the Jaboulay procedure, because it is not a type of pyloroplasty, it is a side-to-side gastro duodenostomy or simple gastroduodenostomy, gastroenterostomy should be preferred, and the gastroenterostomy ideally should be located within 3 centimeters of pylorus on the greater curvature side. So, friends, what I mean to say from this is that if you encounter with lot of adhesions when the anatomy is too distorted or too scarred, or there's a perforation, previous perforation, now patient with gastric outlet obstruction, then the pyloroplasty like Heineke-Mikulicz and Finney are usually not favorable and should be avoided. In this condition, either you can choose a simple gastroenterostomy, that can be gastrojejunostomy, Roux by or loop, and we'll discuss about that also in the later part of this video. Or you can convert to Jaboulay procedure, and that will be a gastroduodenostomy, side to side gastroduodenostomy, and we will discuss about that also. So the first will be Heineke-Mikulicz pyloroplasty. So friends, Heineke-Mikulicz, as I said, is a very simple procedure, simple technique with very less morbidity and mortality. So theoretically, Heineke-Mikulicz will be implied when we are dealing with comparatively simple anatomy. The structure is short and things are conducive for the Heineke-Mikulicz. So theoretically, we will mobilize the superior and inferior attachment on the pylorus side. That will decrease the tension line. And simply, this is the Heineke-Mikulicz. Simply, we open the stricture on the pylorus longitudinally along the length of the gut, and we close it transversely. That is a diamond shaped closure. So as you can understand, that closure will be diamond shaped transversely, and usually incision should be short, because in longer stricture, longer incision, there will be tension on the transverse closure and it can give way. You may add the Cocker maneuver if needed to improve the mobility, but it is not must. So two stage sutures are applied, one at the superior and one at the inferior aspect of the pylorus. We identify the pylorus by pre-pyloric vein of Mayo, and usually we try to take these veins inside the sutures superiorly and inferiorly, and we will demonstrate this also in live surgery. And we usually give 4 to 5 centimeter full thickness anteroduodenal transverse incision, that is incision extending from the antrum to the duodenum. Usually, we keep it longer towards the antrum side, 3 centimeter, and 2 centimeter toward the duodenum side. But we should open the stricture fully, and we should be into the healthy stomach on one side and healthy duodenum on the other side. And we apply the traction at the superior and inferior these sutures, and we close this incision transversely. And as I said, the Gambi suture should be, this is the one place where we should always think of the Gambi suture, and that is our practice. And we will also demonstrate the Gambi suture in live surgery in the second part of this video. So, second is Finney pyloroplasty, friends. So, the indication of Finney will be like when we are dealing with a case of bleeding duodenal ulcer, or these obstructing ulcer, penetrating ulcer, when the anatomy is more deformed and simple transverse closure is not possible, then this Finney is the choice of pyloroplasty, and it requires more dissection as compared to Heineke-Mikulicz, and Cocker maneuver is usually necessary, and it requires 10 to 12 centimeter longitudinal incision from the stomach to the duodenal side, and we close it along the. So it is a type of a side to side gastroduodenoscopy, in which we divide through the pylorus, and the pylorus is the midpoint of this anastomosis. Friends, we could not get any case for Finney. If we in future if we get a case for Finney pyroplasty, then we will demonstrate this procedure in a live surgery also. So as I said, it requires extensive Cocker maneuver, and we place a traction suture at the superior margin of pylorus and mid pylorus, and that is the basically turning point of this U-shaped incision. And we extend incision 5 centimeter proximal to the pylorus toward the gastric side on the greater curvature side, and 5 centimeter distal to the pyloric ring on duodenal wall side. So the wall of stomach and duodenum are sutured together, and these sutures should be placed as near the greater curvature margin on the stomach side and inner margin of the duodenum as possible to ensure adequate room for subsequent closure. A U-shaped incision is made into the stomach from point just above the traction suture around to the pylorus and down to the duodenal wall, adjacent to suture line. You will get a better picture in the subsequent pictorial depiction of the Finney pyloroplasty. So, friends, this is a pictorial depiction. This is a U-shaped incision extending from the stomach to the duodenum, and the center of this incision is mid pylorus, where we give a traction suture, and this U-shaped incision is made approximately 10 centimeter, 5 centimeter on the either side. So, friends, you can pause this video at this place, and if you understand this picture, then you will understand the Finney pyloroplasty. So, as I said, Finney will be required in case of extensive scarring, or when you are dealing with a bleeding duodenal ulcer where you have opened the duodenum and stomach more than, the length required closure is higher and the transverse closure is not possible, then the Finney is the answer. The upper part you can see there is a traction suture which is pulling the pylorus. We have freed the pylorus all around, and then we give this U-shaped incision that is 5 centimeter proximal and 5 centimeter distal. As I said, the incision should be closer to the medial wall of the duodenum towards the basically this pancreatic head side, and on the gastric side it should be closer to the greater curvature because subsequent closure will be easier. Then we close this incision like a side to side gastrotomy, and that can be interrupter closure or continuous closure as per your the desire of operating surgeon. So let's discuss Jaboulay briefly. So, friends, Jaboulay is not a type of plasty. It's not a stricturoplasty. It is a side-to-side anastomosis between greater curvature of the distal stomach, that is the stomach, to the proximal duodenum, that will be D2, D3 part, D1, D2 part. Sorry. So we anastomose the stomach on the GC greater curvature side to the duodenum, that will be D1, D2 part, and it's a more extensive procedure. And we have to take down the hepatic flexure, expose the pancreatic head, and may have to exposure up to the middle colic vessels, middle colic pedicle. So this is a more extensive will be required when the scarring is too much and we are not able to do the Heineke-Mikulicz or the Finney pyloroplasty. So, friends, in Jaboulay, we will understand better in the subsequent part with the pictorial depiction. So, extensive Cocker maneuver is required, and friends, one of the we have demonstrated the Cocker maneuver, extensive Cocker maneuver in our previous video, and I will share the link in description also. So, you can check all the details, nitty-gritty required for the Cocker maneuver. So, extensive Cocker is required, and we do a standard two-layer longitudinal anastomosis between the stomach and the D1, D2 part, and anastomosis usually 4 to 5 centimeter length is adequate. And remember the Finney, it was approximately 10 centimeter. Here we are using only 4 to 5 centimeter. And you have to understand the difference between Jaboulay and Finney is that in Finney we divide the pylorus, that incision extend between the greater curvature, I mean stomach to the duodenum, and it goes through the pylorus. So pylorus divided. But in the Jaboulay, we don't divide the pyloric part, and we simply expose the healthy duodenal part to the stomach on the greater curvature side and leave the pylorus intact because the excessive cicatrization or scarring, any dissection or surgery in this field may be hazardous. So, Javelin is the answer. So, friends, just remember this pic. This is the pictorial depiction of Jaboulay, and we have given an angle stitch as the mid pyloric, and we are giving traction. So there is no need to mobilize the pylorus. There is extensive scarring, and so pylorus is undivided as highlighted. And we approximate the just below the scarring. We approximate the greater curvature of the stomach to the duodenal part. So these stitches are as close to greater curvature and middle part of the duodenum because otherwise subsequent closure will be difficult. So this is the first layer, that is first stitch. Then we will divide these lines 4 to 5 centimeter on either side, and we have already cleared the greater curvature and the duodenal part, and then we first layer simple serosal, then the second layer between the posterior wall of the stomach and the duodenum, then the third layer and fourth layer that will complete our Jaboulay procedure. And friends, as I said, we can simply put endogenic stapler that will be 45 where you can see the duodenal incision mark. So we can put these two limbs, one in the duodenum and other in the uh, greater curvature side of the stomach, and we can simply fire a stapler, and that will create usually will create a bitostoma of 4.5 centimeter, and we can close the enterotomy in usual manner. So, friends, briefly, we will understand the application of these procedure in small bowel strictures also. And friends, just remember the same technique we will employ while dealing with the small bowel stricture. And stricturoplasty is only indicated while dealing with the stricture of small bowel. And any stricture in large bowel is malignant until unless proved otherwise. So there is no stricturoplasty for my junior friends. So these any stricture in the large bowel is malignant, and it should be any stricture in the large bowel is malignant, and it should be resected. So there's no place, and only for small bowel the strictures we can use the stricturoplasty. So this will be a brief recap of the pyloroplasty also, and the technique will remain same. So friends, just remember these figures. These are part of the many multiple choice question while you are preparing for your super specialty examination. So Heineke-Mikulicz, this is like we open longitudinally and close transversely. And as we said, our preferred suture is interrupted gambit stitch. And this can be employed up to the short stricture of 3 to 4 centimeter length only. And any stricture beyond that will create unnecessary tension on the transverse line. So it should not be considered when the stricture length is more than 3 centimeter or maximum 4 centimeter. Be open longitudinally and close transversely. So friends, for longer stricture up to 15 centimeter, the answer is Finney stricturoplasty, and we give a U-shaped incision, and we close this incision as a side-to-side anastomosis, and our incision will pass through the strictureless part. So it is simply a side-to-side closure with a U-shaped incision. So friend, Michelassi stricturoplasty, I have given the reference for this talk Michelassi in this video, so you can check it. And so when we are dealing with a longer stricture or there are multiple strictures, especially when we are dealing with a case of inflammatory bowel disease and like Crohn's disease, so then if we keep on stacking, then we will end up with the short bowel syndrome. So Michelassi stricturoplasty is a beautiful technique, and a stricture up to 20 centimeter long can be dealt with it. So this is isoperistaltic side-to-side stricturoplasty, and multiple stricture or long stricture can be dealt with. And the largest series of 184 patients across 6 international centers found the technique safe with 11% morbidity and 0% mortality, and effective with only 23% of patients when reoperation at 5 years. So friends, just remember this technique, and once in a while you will encounter these cases, and when there will be a dilemma of doing resection, oblique stricturoplasty. So just simply open these and lay these side to side stacked anastomose filosa layer, then open, then just do side to side anastomosis up to 20 centimeter as shown in the figure. And for more details, you can visit this paper. I have given the link here in this video. So friends, if you're watching this video on our YouTube channel, don't forget to like the video and subscribe to our channel and hit the bell icon for future updates. And you can also get connected to us on our app or join the membership for exclusive premium SD content, and that will be available to members only. So stay connected with us on all the platforms. Friends, we started this channel with the notion that the education should be free and accessible to all. But to keep this initiative going, we are charging peanuts, and we will try to upload the operative part on YouTube channel also with the black and white filter to respect the community guidelines, friends. And please stay connected with us on other platform also, and we'll try to make this education accessible. So I'm happy to announce that we are getting viewership approximately from 40 countries in the world, and we are trying to make it accessible to everybody, and we'll uh, keep pushing in this direction. And we hope that with the right education and the right training, a surgeon will be able to help the society in a better way. He'll be able to deliver his services better, and that will serve the mankind uh, in a long run. So the undesired side effects of pyloroplasty will be like pylorus is the sphincter which prevent the reflux of the bile into the stomach, and if the pylorus is dysfunctional, like after pyloroplasty or after Jaboulay, then there will be reflux of the bile that sometimes can lead to a severe biliary gastritis. And in one of our patients, we were forced to convert this into roux and by gastrogenostomy. And if you encounter such kind of problem, then you have to counsel the patient, and you may have to offer the roux and by procedure to prevent the bile from entering the stomach. So another thing is when we are dealing with a case of gastric or obstruction, so there is always an option for pyloroplasty, or oblique gastrogenostomy that can be loop, ruined by, or it can be bone modification of the loop. So, friends, as I said, if we are dealing with a malignant case, then there's no answer for pyeloplasty because it will be palliative procedure. Then loop, oblique, ruined by, whatever is the surgeon choice is preferred, and we always prefer a ruined by procedure for the divergent. Or you can add brown modification, but still the bile will come to stomach. Or if the things are not conducive, or if you feel that the pyeloplasty will not hold, it is too scarred, then always consider gastrogenostomy. And as discussed earlier, gastrogenostomy should be closer to the pylorus, within 3 centimeter toward the toward the greater curvature side, and always create a wider stroke. The second part of this video series will be live surgery in two cases of gastric obstruction after corrosive and chronic DU, and with Gambi stitch demonstration, that will be theoretical and practical demonstration with FG and corrosive injury case. So stay tuned to our channel, and as I said earlier, that live surgery will be available exclusively for the members only section on our YouTube channel or in the app. So the link for app and to join this channel are available in the description. So do check those links and stay connected with us on various platforms. The app is available on Android, Google Play Store, and Apple Play Store. So thanks for watching, viewers, and stay connected. So don't forget to hit the like button and subscribe to our channel if not subscribed already. And we wish you happy learning. Thank you very much.